All this is Dr. Mobeen Sayed from drbeen.com, and welcome to one more show. So today we again have Dr. Priya Jaisinghani with us. She is going through the diabetes mellitus lectures with us. Dr. Priya, welcome. Dr.
Thank you
J,
so
welcome.
much. Thank you so much, Dr. Mobeen, and welcome, Cool Beans. It's so nice to be here again. Very, very grateful for the opportunity to be here lecturing again. So today's a very exciting discussion. We're actually going to have a pretty high-level discussion on carbohydrate digestion, how and where carbs are broken down, where the absorption of those molecules happens, and then, how they're in the digestive tract, how they move out of it into the circulation and get distributed through the body. So, Dr. Mobeen, I'm very excited to present this lecture, so I think we can dive right in. So we can begin.
Let's start. So this is the slide. I hope you can see it and just guide
Yes.
me and we will go
Sure.
from
So we
there.
can begin with the first line. Wonderful. So, let's just start with some basics. So we know that all food is composed of molecules. So larger molecules are broken down into smaller molecules. And that usually happens. The first step is through digestion. And then, once it's broken down to smaller molecules, then we have those smaller molecules that are absorbed into the bloodstream. And today we're specifically going to be talking about carbs. So we can go to the next slide. So, when we usually talk about carbs, we think about our healthy plate, right? So we think about our half plate of vegetables. We think about the vegetables and fruits. We think about a fourth of the whole grains. And carbs are found in our diet very abundantly, right? So we're talking about starches, fibers, sugars. And you'll see that a lot of our dietary carbs actually come from plants. So when we're talking about dietary carbs, they're broken down into two main categories: complex carbohydrates and simple carbohydrates. So we can think about, the complex carbohydrates being analogous to the larger molecules, which we're referring to, which is going to be, your polysaccharides and disaccharides. And the smaller molecules, or the simple carbohydrates, are the monosaccharides. So what do I mean by polysaccharides? Well, these are your starches. So like potatoes, breads, wheat, oats, beans. Then we have glycogen, which is a storage form of glucose. And then we have cellulose, which you can think about as parts of plants, fibers, so your green leafy vegetables, beans, lentils. And then you have your disaccharides. So these are molecules such as lactose, maltose, sucrose. And then you have your monosaccharides, which are fructose, glucose, and galactose. And we'll go through all of this a little bit later as well. So, as I mentioned, all complex carbohydrates are going to be converted into simpler forms, which are absorbable. So we have complex carbs, which get digested. They go to monosaccharides, which are then absorbed. Okay. And then, naturally in the body, there are a lot of other smaller molecules which can be absorbed, like your vitamins, minerals, things like that. So let's go on a journey and see exactly how these carbs are digested and broken down further. So we can go to the next slide.
Got it. If I have a question here, and this is
Sure.
actually my own curiosity as well. So,
Yeah.
quick question. So, here we say a lot in the Western societies, and I think it is now prevalent in the world as well, that processed foods, refined foods, they are causing a lot of problem in terms of early diabetes or carbohydrate issues, and more plant-based foods will be better. My question to you is, and that may be in the context of meat versus plant as well. My question to you is it actually possible to be on plant-based diet and still be uh, unhealthy or eating unhealthy?
Yes. So, I think a lot of times we tend to forget that it's really an interplay between our genetics and our current lifestyle, right? So it can be our environment, but it's also with our genetics. And what I mean by that is ethnicity as well. So there are a lot of ethnic groups which may be eating mostly, plant-based diets, but they still hold a lot of risk factors for other disorders. The other thing is, when we think about, I think sometimes when we think about carbs, people tend to forget that we want carbs that are high in fiber, or they forget that, carbs are not your basic just rice, bread. There are also other things which have hidden amounts of carbs. So, like I said, a lot of our carbs actually come from plants, right? So, carbs are not bad. There's nothing bad about carbs, but I think, it has to be a very balanced and tangible plate according to your one, medical conditions that you already have, and two, what you're predisposed to watch out for those things.
Got it. Thank you very much. Back to
No
the
problem.
discussion.
Yeah. So, and we'll definitely talk about it a little bit more. I think medical nutritional therapy is something that is so cost effective and very in the know right now. Where there's a lot of research going on with just the way we make up a balanced plate, the order which we eat our plate in, what we eat other foods with. So a lot of that can actually contribute to our health, and we'll definitely touch base upon that too. So we'll talk about that as well. But getting back to
Got
our
it.
journey about how carbs are digested, so we'll basically start off with this diagram, and you'll see this diagram as kind of a recurring theme throughout our lecture today. So, we're going to begin with the breakdown of food, which is first starts off in the mouth, right? So we have our piece of food, we place it in our mouth, and we start to chew. So this is the breakdown of food molecules, which is chewing, which is called mastication, right? So you actually have a mechanical breakdown of these large food particles into smaller food particles. And then what happens when we eat? We start to develop saliva, right? So when we have saliva that's being formed in the mouth upon, contact with the food, then we have a chemical breakdown which begins. So first we initially had a mechanical breakdown. Now we have a chemical breakdown. And what this is actually breaking the bonds of the molecules with digestive enzymes. So what's really in our saliva, right? Our saliva actually contains a carbohydrate splitting enzyme called salivary amylase. And what happens is that it begins to break down these polysaccharide molecules that we were talking about. And it actually breaks down some of the glycosidic linkages, or the linkages that are in between the glucose bonds. So that's basically what happens. So in the mouth, always remember it's two types of breakdown. One is mechanical and the other is chemical. And this saliva that has this enzyme, the action is pretty much limited to the mouth. And why is that? That's because the pH is optimal there, at which this enzyme actually functions at, which is about 6.7. So the pH in the mouth is anywhere between 6.6 to 6.8. We'll see that enzyme won't work in the stomach because the pH falls, because it's an acidic environment, so it falls to 3. So, I would say in the mouth, the starch digestion is probably about 20 to 40%. And again, the drawback is the shorter duration of time, right? So the old advice that we used to get from people was take your time and chew your food. And that was for a good reason, right? One, you probably have more mechanical breakdown, but the other thing is you're going to have more contact of the saliva with the food particles to break down the food. So there is some science behind this extra time slowing you down to chew your food and actually increase time with the enzymes and, facilitate digestion. So now we'll keep going. So then we swallow our food and we are going to have this peristaltic wave and propulsion of this food bolus going down the esophagus, right? So now we are actually heading towards the stomach. And so when, the food bolus is moving down into the esophagus, you're again just having some sort of mechanical breakdown. There's no enzyme there to break the glycosidic bonds. And then once you reach the stomach as well, there's a gastric juice, right, which has HCl, or hydrogen chloride, in the stomach. And that basically, again, it's not going to break down the carbs. It actually activates protein digesting enzymes, but you'll continue to have this mechanical breakdown and propulsion that'll keep happening. And then from there, we're actually going to reach the small intestine. So we can, yep, exactly. So there we go. The arrow had changed, and now we're in the small intestine. And this is where, the main digestion really occurs, and it accounts for about 50 to 80%. And, the main digestion really occurs here because food is staying here for a longer amount of time, one. But again, we're dividing it into two different phases. So here we have, from the stomach to the first part of the small intestine, it's called the duodenum. And in the duodenum, you're going to have, another type of juice, which is pancreatic juice, which is going to meet your food bolus. And the pancreatic juice actually contains another carbohydrate splitting enzyme. And this is an isoenzyme of salivary amylase. It's called pancreatic amylase. And what do I mean by isoenzyme? It basically has the same function. So the function is, again, to break down those bonds that we were talking about. And here, the pH is similar. It's about 7. So we're going to keep breaking down our starches, our glycogen, and it's going to go to some sort of a maltose or, other dextrins or smaller, polysaccharides. So, We can go to the next slide. That's fine. Exactly. So here we'll see, the brush border is there where this, this reaction that we see on the right side is really going to be happening. So this is a reaction which is, found to happen through disaccharidases. And disaccharidases are present in the brush border epithelium of the intestinal mucosal cells. And what do I mean by that? Well, we call it a brush border because we have these little microvilli, these little outward projections, which really, form this brush-like appearance. And, that's for many different reasons, right? And where you're having digestion and absorption, you want a lot of contact with the actual food bolus in the food. And that's why you have that to kind of increase the surface area and contact. So within that, we have these enzymes called disaccharidases. And what do? They're going to break down the disaccharides. So we have some enzymes that are responsible for that. And we can see the reactions here. So maltose is broken down by the enzyme called maltase into glucose and another molecule of glucose. And then sucrose is broken down by sucrase into glucose and fructose. And then we have lactose, which is broken down by lactase, and it's broken down into glucose and galactose. And just as a side note, I'm sure, many individuals have heard of lactose intolerance, right? So this is when you have the inability to digest lactose, and that can be due to a deficiency of the lactase enzyme. And so I just wanted to throw that in there because, since we're talking about the reactions, this is where, we see the deficiency really when it comes to lactose intolerance. So we can go to the next slide.
So one more question.
Mm-hmm.
The lactose intolerance. So I know that there is a medical answer, but I want to ask this. Is it actually possible to administer lactase from outside with the food? Would that help?
Do you mean like if someone's having a slice of pizza and they're lactose intolerant, if they have lactase? Yeah, I've seen people do that. I really have seen people do that. So I have seen that happen, but they do
And
say
does
sometimes
that work well?
they say some people say it helps with their symptoms, so I have seen that for sure.
Got it. Thank you.
Yep, because otherwise, they have a lot of pain, cramping, digestion problems, diarrhea, because a lot of that then becomes undigested lactose. And so if you have the enzyme, then, that can help with that.
Got it. Thank you.
No problem. So before we talk about what happens to these monosaccharides, when they're arising from the diet and, being absorbed, I just want to touch base on our friend, the pancreas again. So we'll notice, the pancreas has a big role here. So we can move on to the next slide. Perfect. So here we have the pancreas. And so we saw that, digestion of carbs, there were different enzymes involved, right? So we had amylases breaking down, polysaccharides into dextrins and, disaccharides, and then disaccharides were broken down into monosaccharides. And then after eating, a meal with carbs, usually our blood level tends to have a lot of glucose in it, right? So we have higher and higher levels of glucose in the blood. And what ends up happening is the pancreas, there are cells called beta cells in there, and they sense this increase in the blood glucose, and they want to release a hormone called insulin. So we've heard about insulin. It usually, sends a signal to the body cells to either move the glucose from the blood by transporting it inside cells and use it as fuel, or either it gets stored. So glucose can be stored in muscle and in liver tissues. And in these tissues, it's stored as glycogen. So remember, we briefly had mentioned that earlier. So, glycogen, we mentioned, it's a highly branched macromolecule, and it has thousands of glucose molecules within it. So we can go to the next slide.
So I have a comment here. So those little beta cells in the pancreas, so do they act like a glucometer? Our own
Very
organic
similarly,
glucometer?
very similarly. And they actually have a buddy, they have alpha cells, which actually act as another meter. You can definitely think about it that way, and when, the levels are high, insulin kind of gets notified. The beta cells release that insulin. And when the sugar levels are low in the blood, we'll talk about another hormone, which is glucagon, right? So insulin has an opposing hormone, which is glucagon. And, you can imagine after, a meal time goes by, the glucose levels in the blood might tend to decrease. And when that happens, alpha cells in the pancreas actually sense the drop in glucose and they respond and they release glucagon. And, our body has all these mechanisms because we'll come to see that, having a very targeted range of glucose is very important. And we've seen that, right, in the real world. We see all of these metabolic disorders happening. We see an uprise in diabetes. So this is very, very important. And we'll see how this actually plays a key role into things like diabetes and what actually can go wrong with insulin resistance or insulin deficiency. So we'll definitely touch upon those things. But that's a great question. Yes. So we in our bodies have these automatic kind of mechanisms to monitor our blood sugar levels in a very targeted range.
Got it. So I always think about these little cells as little lab of glucometers and working. So I have a question here. Robin Huber says, have lactose intolerance. Question, what about intolerance to high fructose? What causes that?
Yeah, so many different things can actually cause an intolerance to fructose as well. I'm sure down at the cellular component, even receptors, even the absorption, right, where it's happening, and we'll see how fructose is absorbed. There are multiple things which come into play when you're talking about digestion and absorption of these monosaccharides. So even sometimes having a bowel disease, right, inflammation in the bowel can lessen that absorption, which can lead to intolerances. Medications can change that. Some genetic predispositions can change the way the receptors are, or little pathways inside the cells which lead to the receptors to act or absorb things. So there can be genetic deficiencies. It can be your environment as well. It can be different medications that can affect it. So lots of different factors actually can cause alterations in the transit time of these monosaccharides, in the actual layering of the intestine and the lining of it. So we'll also touch upon that a bit.
Got it. Thank you very much.
Of course. So, getting back to our pancreas, so our friend here. So, as I was mentioning, there are definitely, opposing um, um, hormones, insulin and glucagon. And we saw how the carbs can be broken down through different mechanisms, right? Amylases and disaccharidases. And eventually we have the monosaccharides, and then those are absorbed. And before we get into that, as I was mentioning, when we have higher levels of glucose in the blood, insulin is kind of triggered through these pancreatic beta cells. And so we can go to the next slide and we'll go into a little bit of detail about how exactly, insulin is released from these pancreatic beta cells. So this slide looks very overwhelming. We're going to keep it very basic, and we're going to probably go into more detail a little bit later. But basically, what I want you to understand is that this is functioning as a pancreatic beta cell, this diagram right here. And if you look at the top, you have glucose, and that's the glucose in the bloodstream. And what we see here is this little blue thing sitting at the lining of the cell, and that's a glucose transporter. And the name of this glucose transporter is GLUT2. And this is the transporter that we see for glucose that sits on the pancreatic beta cell. Now, it kind of grabs the glucose and pushes it into the cell, where glucose is, broken down through a process called glycolysis, goes through something called the citric acid cycle, goes through oxidative phosphorylation, and makes this thing called ATP. Now we'll talk about ATP, but ATP is basically energy currency for cells. So you have this energy currency that's produced, and what the ATP actually does is it stops the potassium efflux from cells. So it stops this potassium from leaving the cells, and what that does is kind of change the voltage inside the cell. And so you actually have an increase in the amount of calcium that's then coming through the cell, and that calcium influx actually causes insulin to be secreted. So it's a bit of a long pathway, but you can see how when glucose is absorbed, it goes through several steps to make ATP, which then affects the voltage, the potassium, the calcium gets increased, and then, you have this release of the insulin secretion. So that's how the pancreas really releases insulin. And, that's how it's very tightly regulated as well. So, from here, now that we've talked about the complete process of digestion and that once glucose is sent in the bloodstream, insulin is released from the pancreas, we can go into how it's absorbed, right? So we can go to the next slide. So absorption, is the process by which the end products of digestion or these monosaccharides are going to pass through the intestinal mucosa. Okay, and so they're going to be transported through the intestinal mucosa into the blood. So that's what we're seeing here in this diagram. Okay, and so the end products of the digestion are absorbed in the jejunum and the ileum regions of the small intestine. And so there's three basic mechanisms by which things are usually absorbed. So we can go to the next slide and we can take a look at them. So, the three mechanisms that I have listed here, one is passive diffusion. Okay, so this is the simplest mechanism by which molecules can cross a plasma membrane. And a molecule through this mechanism just simply dissolves along the bilayer, the phospholipid bilayer, and it diffuses across. And there's no helper proteins or membrane proteins involved like how we saw with GLUT2. This is just, pure dissolving of the actual molecule moving across. And so that's why, there are only very specific things that can kind of travel this way. It's usually gases, O2, CO2, small polar but uncharged molecules, water, ethanol. And so, as I said, there's no real carrier protein. The speed of this is usually pretty slow and there's no energy expenditure. So that's one way. What we're really going to focus on when it comes to carbs is more of the other two types that we have listed here, which is, facilitated diffusion. So that's the next one. Yes, carrier mediated. And so here, you're moving down from a high to low concentration gradient. And that's why you still don't have any energy expenditure. But there is a carrier protein which is required, which will help, and the speed becomes faster with this. Then the third type we have is called active transport. And here, it's active. So it's actually going against the concentration gradient. So you're going from a low to high. And because of this, you have to pay with currency. So you have some energy expenditure that is needed here. And that we'll see is, in the form of ATP, that molecule which I mentioned earlier. And we'll talk a little bit about, why it can actually provide energy in the cell and why it's used as a currency. And, with this active transport, you actually need a carrier protein or a transporter, which is required. And this is usually the fastest speed. So you can almost thinking about it like, sorry,
please continue. I'll make a comment afterwards.
Sure. I was going to say, you can almost think about it like paying the toll, right? So you pay a toll and you get through speedy quick on a roadway. So that's how it is.
Got it. And I was going to make a similar comment. So I have all these cute mechanisms in my head. So I always think of this ATP, that we eat food to make money. And then that
Yes.
money is given to various cells and they spend that money to get their business going on. So the whole body is actually a big marketplace where the food that you ate is the money, and then the cells are using that money to do their businesses. That's so interesting.
Exactly. No, I absolutely. Every reaction in the body that requires energy, ATP can be used. And the good thing about ATP is that it can be broken down and then kind of recycled. So, I'm sure we'll also talk about that in future lectures, but absolutely, it's truly the currency that we get from our food. So, yeah, but thank you so much for that, Dr. Mobeen. And so now we're going to talk about two very specific types of transporters. So there are actually two types that we're going to talk about. One is sodium-dependent transporters. Those are called SGLTs. And then we're also going to talk about another type of transporter called sodium-independent transporters. And those are your GLUTs or GLUTs. Okay, so we have 5 of them listed here. There's actually probably 14 different types. So we have 5 listed here. And what I basically want to point out is that one, they're in different locations. And the ones that we're really going to focus on are the ones that we'll see in the small intestine. So we can see GLUT2, is in the small intestine. And GLUT5 is also in the small intestine. Now, there's one other, very special GLUT listed here, and that is GLUT4, because it actually depends on insulin. And we'll see how that actually comes into play as well. So just remember, try to focus on these three: GLUT2, GLUT4, and GLUT5. We also see GLUT1, which is seen in the blood on red blood cells. It's seen in the blood-brain barrier in kidneys, not dependent on insulin. And then we also have GLUT3, which is also, more in neurons in the brain, and it's also not dependent on insulin. So those are the 5 types of sodium independent transporters, or GLUTs. And those are the main types. Like I said, there's many more, but those are the 5 that I'll list here. And then the next slide, we can see we have sodium dependent transporters, right? So here we have our SGLT transporters, and we have 2 that are listed here, SGLT1 and SGLT2. And we see SGLT1 is in the small intestine. So we will definitely see that as well. So we can go to the next slide.
And just a comment for the cool beans here. Cool beans, I'm going to ask you as a test that what are the glucose transporters that need sodium to function versus those that do not need sodium for a function. So these are the 2 slides to keep in mind. All right, we're going to go to the next one.
Yes. So since we had a little quiz question, we'll also take some time to do a quick recap here, I think. So we walk through how carbs are digested. They're broken down from larger molecules of polysaccharides to disaccharides. They get broken down to smaller molecules. And then, digestion began in the mouth, right? We saw it in the mouth with mastication. Salivary amylase had passed through the esophagus into the stomach, continued with mechanical breakdown. Then we ended up in the small intestine. We had the pancreatic amylase. We had disaccharidases. We broke down into, simple carbs like monosaccharides, and now we're ready to be absorbed. So here we are. So now we're actually in the small intestine. This is the lumen, and we can see, how do monosaccharidases get absorbed from the bloodstream? So we just talked about different mechanisms, right, through which carbs can be transported. And we talked about how they require transporters. So here we have the lumen, and then we have the apical side. And that's where we see SGLT2 and GLUT5. So the first transporter, we can talk about is SGLT1. So we mentioned this is what type of transporter? This is a sodium-dependent transporter, right? So it's going to transport glucose or galactose across the membrane. And so it's sodium-dependent. So it's actually linked to the sodium-potassium ATPase, which we see up at the top there. And so that is necessary for maintaining a gradient for the SGLT1 transporter. And sometimes, we were talking about intolerances. So, for example, you can see a mutation, in this transporter gene, which can actually lead to a glucose-galactose malabsorption. And that's often seen in neonates, and it usually presents with severe osmotic diarrhea. So that's one example that you can have. And then, going to the second transporter, you have GLUT5, right? So that's responsible for transporting fructose. So now you have your glucose, galactose, and fructose that are now inside the cell. Okay, and the goal is to move them from inside the cell to the bloodstream. So how do we get there? How do we cross the basolateral side of the membrane? Well, we have another transporter, and that's called GLUT2, which is located there. Okay, so GLUT2 is going to help with that transportation. So now we're going to have the glucose actually reach the bloodstream, and the levels of glucose in the blood are going to begin to rise. And remember, we talked about that, glucose levels in the blood need to be very tightly regulated, because if there's too much or too little, that can have bad effects, right? And so the beta cells in the pancreas are going to release insulin. Insulin's going to send a signal to the body. It's going to cause uptake of the glucose. It's going to remove it from the bloodstream, transport it into cells, either use it as fuel, or it's going to get stored. So exactly how do we have this uptake, right? So glucose, like I said, can be stored in muscle and liver tissues. So if we can go to the next slide.
So I just want to make a comment here. This is, again, you would find out, Priya, as you work with me, that I love mechanisms. So here, this is such a cute mechanism that we have eaten food to make more money for the cells.
Yes.
But to get those food particles, the raw material for money, into the right places to make money, we have to spend money here
Yes.
to get them to move, right? So this cell here needs money, ATP, to move sodium out. And when sodium has gone out, that reduces the amount of sodium in here, which, as you were saying, would then cause the sodium to go in, and with that, the glucose goes in, and then all the way towards the blood. That's it's crazy. It's a business. It's a
It's
market system.
fascinating, right? You have exchanges and they can be either for or against. And then that depends on if you have to pay with your currency or not.
Yes, that's
So
beautiful. I love
absolutely
that.
amazing.
Yeah.
So here, jumping back to the diagram. So here now, like I said, we have our glucose in our cell, and glucose can be stored, like I said, in the muscle or the liver tissues. So we're going to have another GLUT that's going to help with that. And that is going to be GLUT4. So remember, we were talking about how GLUT4 is special because it's going to be dependent on insulin. So we can go to the next slide. So here, when there's actually no insulin present, we can see GLUT4 is actually inside the muscle and the fat cells, right? And upon it seeing insulin or having insulin stimulation, and actually even with muscle contractions, GLUT4 is going to translocate. And what I mean by that, it's going to actually move from inside of the cell to the compartment up towards the top, towards the border of the cell surface. Exactly. And here it's where it can actually transport glucose from the outside of the cell to inside. So here, this is basically insulin regulated glucose uptake. And that's going to make GLUT4 a key player for, maintaining normal glucose regulation, or what we call as homeostasis, right? This balance. And it's going to be a very important and key element that we're going to see in insulin resistance and type 2 diabetes. So that's why with these conditions, we always recommend exercise, right? So exercise is actually critical to managing blood sugar levels, because it's, like I said, it's one of the things that is actually going to drive this transporter. Right. And, in diabetes, sometimes the pancreas is not making insulin. Insulin receptors maybe are not stimulated. Maybe GLUT4 is not stimulated, and that leaves elevated sugars outside of the bloodstream. So in diabetes, there can be a problem with GLUT4, which means that there's a problem with the muscles and the fat taking up glucose. And, I mentioned before something called insulin resistance, right? So that can be maybe even the machinery inside the cell, that's responsible for taking GLUT4 maybe to the cell surface might not be working properly, right? So maybe you have defective intracellular signaling, what we call, in that actual translocation, so the movement of the receptor. You can even have the receptor itself not working very well, or you can have, maybe down regulation of the receptor, so maybe not enough representation of that receptor at the cell surface. So these are some things which we might see in diabetes. So, a lot of diabetes drugs actually target to increasing and making insulin more available, right? So sulfonylureas are one class that do that. They try to stimulate the release of insulin from pancreatic beta cells, and they do that through, inhibiting potassium channels responsible for insulin uptake from the cells. But by blocking that process, they actually increase the insulin availability. We also have drugs like the glitazones, right? The TZDs, which improve insulin sensitivity. They can even improve, GLUT4 translocation through a variety of mechanisms. So a lot of diabetes drugs are actually targeted by increasing insulin availability or increasing insulin sensitivity. So it becomes a bit of a complicated process, but everything is tied together here. And that's why, Dr. Mobeen, I absolutely agree with what you said. Mechanisms are amazing. This, when we come down to the nitty gritty, when we come down to the cell biology, and we see how it's connected to the pathophysiology, it's absolutely incredible. So that's a little, tidbit that we went into there. A little complicated, but I think important to know.
So I have a question for you over here.
Yes.
Sorry.
No, that's fine.
So the question is, you mentioned that sometimes the cell structural change might also cause the GLUT4 to become fused with the surface to allow more glucose to come in.
Mhm.
Is that the kind of mechanism when we ask a diabetic patient to say, please do some exercise or go walk more? Does that help with the insulin glucose levels
So exercise will actually cause the GLUT4 to actually go to the surface. And
without
so,
the need of insulin?
yes, so that will act through a different mechanism, and that is through AMPK. That pathway involves AMP kinases, and insulin actually works through a totally different mechanism. It's phospho, PI. I think it's PI3K, which it actually works through. So they're working through two totally different mechanisms, and that's why I say, along with insulin, exercise is so important because it can actually help. You know, down at the cellular level even.
Wow, very good. Thank you.
So I think we can actually go to the next slide. Yep. So I just want to talk about one quick note here. So what actually happens inside the cell when glucose is inside the cell, right? So this is pretty important to at least mention, even though again, very complicated process, but we basically have glucose, influxing into the cell, and it can be metabolized for energy, or it can be stored as glycogen, or it can be used for lipid synthesis. And there's basically 4 steps of aerobic respiration, right? So you have glucose going through glycolysis, and then here we have currency being made, right? So we have 2 ATP that come out of that. Then we have, oxidation of pyruvate, and then we go through the Krebs cycle, which we have another, or the citric acid cycle, which we have another 2 ATP. And then we have the electron transport chain, which is going to be 32 ATP. So that's about 36 ATP in the currency. And, the use of ATP, like we were saying, is really a universal energy, right? And it's used for all our energy dependent processes. So ATP is called the energy currency of the cell. And why is it really called that? So what's so special about ATP, right? So within ATP, you have 3 phosphate bonds, which are high energy bonds. So when these bonds are broken down, you have the release of energy. And that's why, those bonds can be utilized by cells whenever, you have that breakage in these phosphate bonds. And we see it used widely when we go into different, exchanges that happen in the body. So we'll
Got
see
it.
that very, very often.
And this is a mitochondria, correct?
Yes.
Got it.
So that's a powerhouse
Very
of the
good.
cell.
I love it. So I love this idea as well that the ATP is 3 phosphate bonds. And imagine somebody has 3 pockets filled with money. And when you take one phosphate off, then it becomes difficult to take the second one off. So it's like if you take money from my one pocket, I'm going to become more conservative to say, don't want to give you more money. And if you take the money from the second phosphate bond, then the AMP breaking that down is really difficult. So I hold on to my last piece of money and said, I don't want to give it to you. It's a beautiful
Exactly.
mechanism. Got it. Please,
Exactly.
back to you.
Of course. So we can go to the next slide. So here, this is the whole process where I talked about kind of glucose catabolism, right? And really channeling that energy. But, where do our proteins and fats kind of fit into this, right? So proteins, we can just briefly mention that they're broken down actually into amino acids, right? And excess amino acids can actually be converted into molecules that are going to feed into this pathway, into the glucose catabolism pathway. So we can see some amino acids, they'll some
So, Priya, we lost you for a few seconds.
Oh, I'm so sorry. I don't know what happened.
We lost you when you're talking about amino acids. Some amino acids would be used in this.
So some amino acids are actually converted into, molecules like pyruvate or acetyl-CoA, and some components of the citric acid cycle actually, so they can feed into the pathway of glucose catabolism that way. Now, can the reverse also happen? Can proteins lead to the production of glucose, right? So some of the amino acids actually have the ability to become glucose because, they feed into the Krebs cycle intermediates in a process that we call gluconeogenesis. And what that means is, the production of glucose. So, that feeds into pyruvate, which feeds into another molecule called oxaloacetate, which feeds into something else called PEP, which then leads to glucose. So we'll go into more of that probably in other lectures as well. But those are some of the ways that, some amino acids have the ability to do that. So, pitfalls kind of come up when our body, if we think about a scenario where we have starvation mode, right? So starvation mode, maybe your body will use up all the stored glucose and has a glycogen. And next, it'll be looking at the proteins. Well, are we going to use up the protein? But do we really want to use up the protein? Because in our body, our proteins are really responsible for making up a lot of our muscles, making up a lot of other things in the body. So in prolonged starvation, we actually see a shift from using protein that can be used, for muscles, enzymes in the body to actually shift to ketones. And so that we can often see. So we can definitely talk about that as well in detail at some point. But the other, interesting thing which I want to talk about is lipids, right? Or fat. So where does that really play in? So again, we have fats that are broken down to fat globules. It can be broken down into glycerol, into fatty acids. And again, we see fatty acids feeding into the pathway here. So fatty acids get broken down into acetyl groups. And then, the acetyl groups can be used to make acetyl-CoA. And then that can feed into the citric acid cycle again. And we also have some production of other currencies, that are called FADH2 and NADH. So those are other currencies which can be produced in that way. And the thing with fats, however, is that, they can be broken down into fatty acids or glycerol, and glycerol can be metabolized to make glucose, but fatty acids cannot make glucose. So that's really a distinction there that, can be made. So, oftentimes we get asked if glucose can be gotten from proteins and lipids. So that's why I just wanted to touch upon that very briefly. The other very interesting thing is something that we touched upon in the beginning. I think one of the cool beans had asked a question relating to kind of, alluding to the presence of other items on the plate when it comes to carb absorption, right? So when we're talking about that, we're talking about non-carb macronutrients. So that's going to really include things that we're talking about here, right? Lipids, proteins. So can that actually affect your carb absorption, right? That's a very interesting question. And there's actually been a lot of research done on this recently, and there's a lot of upcoming studies as well. And one thing that's really fascinating is that a lot of factors, like I said, actually affect or influence, the way carbs are digested in the small intestine. So that can be your rate of digestion. That can actually be the actual food form, right? The physical form of the food, the way it's prepared, the transit time, the amount of fiber, fat, protein. So ingestion of fat and protein actually with carbs, they
We lost you once more.
Okay, sorry. I'm not sure what's happening here. I'm in a little bit of a glitch today. Sorry, cool beans. But I was saying that when you have ingestion of proteins and fats, when you preload with that prior to your carbs, actually what they saw was in some studies that there was a more I just paused at 120 minutes. Did you hear that?
No.
I will repeat my sentence. So what they found was when you have ingestion of proteins and fats, if you preload with it prior to your carbs, which are, if you preload prior to your carbs, you can actually have a more rapid decline in glucose concentration. And it'll actually be even a lower amount when it comes to the nadir of glucose. And so this really brings up an interesting topic, right? Imagine if you could control to some degree the amount of carb that was absorbed and at what rate it was absorbed, right? Because this is going to be, like I said, very important for diseases like metabolic syndromes or type 2 diabetes, anything that really has a risk factor for, cardiovascular diseases or stroke. Imagine, medical nutritional therapy. It's ineffective. The cost is much lower than medication. So, our food is really medicine. And so this brings up a very interesting concept of something called a glycemic index. And a glycemic index of food can really be, a classification of carb foods based on the rate that the carbs are absorbed at. And that'll be reflected in your bloodstream, in the glycemic response, really. So, that's one thing to keep in mind. And then another interesting thing which has come up in research lately is actually the order in which we eat our food. So even if you don't preload prior, they suggest that if you eat your carbs towards the end of your meal, your sugars won't rise as high. So these are all up and new coming things which are being studied, because imagine you can control how your sugars are not only by the food you're eating, but the order of the food you're eating it in. So it's really
That's
fascinating.
fascinating.
Yes, it's truly, truly fascinating. And like I said, being in endocrinology, it's really, really important because dietary changes, lifestyle changes are usually one of the first things that we recommend when it comes to, management of diabetes. So nutritional interventions, I think, are key. And like I mentioned, exercise as well. So I think today we got a bit of insight into how we really go about tackling these problems from a molecular level to an actual clinical basis, from looking at something down to the cellular level to how we actually treat it in real life. So just going to the next slide. I just wanted to give you a quick overview. So we covered a lot of information today, from going through the digestive tract to the absorption. So, just once again, we took our carbohydrates that we put in our mouth. We went, through a mechanical breakdown, a chemical breakdown, and went through the esophagus into the stomach, had some feedback there from the pancreas, then went into the small intestine again, had more breakdown into monosaccharides. Then we had our insulin being released, driving glucose into different cells, especially where it can be stored. And then, we had important transporters like GLUT4, which were mentioned. And we also saw how glucose can lead to the production of energy, or the currency of the cell, which is ATP, and how ATP can be used, and how, fat breakdown, lipid breakdown, or protein breakdown can also help with that process, and where exactly it feeds into that process, and kind of really creates the currency for which our body can use to, use that energy currency during different processes. So this was the whole breakdown of that pathway.
Excellent. I loved it. This has actually, I just want to show your Twitter account over here so folks
Sure.
can follow you there.
Thank
And I'm
you.
going to now bring so please, there is actually one more thing. I think um, you should have your own YouTube channel as well,
Oh,
because you were planning for that too, correct?
yes, I think eventually I definitely want to start on that. I've been on a couple of social media platforms. Now Twitter is, one of them. My Instagram is just picking up, so I'll be sure to include that the next time. But I do share a lot of, medical information on Twitter. And I do, love medical education. I love coming here, Dr. Mobeen, and, speaking to the cool beans and answering their questions. I really enjoy educating and, passing on the knowledge that I've learned in a very simple way, where it's able to be broken down and absorbed, just like how we, discussed with carbs. I think, complex information should be understood by everyone. And if it's broken down the right way, we can do that. I think I've had a lot of great teachers that have, taught me that teaching is a skill. So I really hope that, one day I can have my own YouTube channel to kind of disseminate that information, not only to healthcare providers, but to the people that we see as our patients, because I think everyone should be an advocate for their health. So,
Absolutely. And especially nowadays, the lifestyle, the changes in lifestyle, the food, as you said, the order of the food, eating maybe preloading with one type and then eating the other type. These all are simple and important things. What is a healthy plate? What does it mean to have a health? What is the mechanism of that? I feel that once we understand the mechanisms, it becomes easier for us to follow them. But if we don't understand the mechanism and somebody just says, do this, we usually have hard time just following things that way.
Yes,
So your channel
absolutely.
will be very, very much needed.
Absolutely. I'm looking forward to it under your guidance, Dr. Mobeen. And with the support of the Cool Beans as well. Thank you so much for attending these lectures. Thank you for your questions. I'm very, very appreciative of it. I know even after the first lecture, a lot of them reached out, and I had some wonderful comments come through on Twitter and Instagram as well. So thank you so much for all of the love and support.
You are very welcome. So I'm going to look at some of the questions from the Cool Beans here and see if we can
Sure.
answer them. Let's see. There were so many questions in the beginning. Is this so how does chromium fit into all of this?
Oh, that's interesting. So, with chromium, I don't know down at the molecular level where exactly in this pathway that would fit. So I wouldn't want to give you any incorrect information with that. But yes, there are, a subset of smaller molecules, vitamins, which are integral down at the molecular level. But with chromium, specifically in this pathway, I'm not really sure. Do you have any insight into that, Dr. Mobeen?
No, I'll have
At
to
this,
read up. I
yeah,
heard that for
same.
the first time. So there is another interesting one. Robin Hood 46 says, what are your thoughts on the WHO statement that air pollution increases type 2 diabetes risk? That's an interesting statement.
Yeah, so I'll have to read into that statement, but I do think, we do have a lot of factors in the in the environment itself which can affect um, you know, different endocrinopathies. And we see that, not only with diabetes, with and we call them environmental factors, endocrinological environmental factors with different things, and we often see that even with thyroid disease. So I'm not surprised, if they've mentioned some of those factors for diabetes as well. Because like I said, with endocrinopathies, it's really a very fine balance between your environment, your genetics, and then your actual lifestyle. So I will definitely read up on air pollution specifically with diabetes, but I would propose that a lot of inflammatory conditions or inflammation that kind of lead to um, you know uh, this sort of inflammation will have a big role to play in metabolic disorders.
Got it. So next question. Question is from Thrill0415. Amino acid supplementation, can that be effective?
Yeah, so I know that's very popular in certain communities, especially a lot of fitness communities. I haven't seen any proposed research saying that intake of those amino acids, will provide very clinically effective differences. But I think I'm of the mindset that if something is we've seen where amino acids can play a role in the pathways that we talked about today. So I'm of the mindset that as long as things aren't harming you and your physician is informed about supplements that you're taking, and it's not having a bad interaction with your medications or any of your other medical conditions, I think that's fine as long as someone's informed, on board, and monitoring you appropriately.
Got it. And once again, these are educational topics and discussions. These are not advice at
Yes,
all for anyone.
exactly. Yeah, I would definitely say for any of that advice, you definitely want to speak to your doctor because, I think they are more well versed with your medical history, the medications you're taking, all of that stuff.
Got it. So looking at Twitter, there is a question that I'm going to kind of paraphrase. And the
Sure.
question is about nowadays with COVID and diabetes
Yes.
and vaccines. So the question they're asking is, if I'm diabetic, do I go for vaccine? Is there any harm in approaching vaccine? Should I take it right away? So you may have seen patients who are diabetic taking vaccines. What are the experiences that you are seeing?
Yes. So I would say that your risk as a diabetic in an environment where COVID may be rampant, is actually the risk is higher with getting COVID and your outcomes being worse than you not getting the vaccine. So I would say when we make medical decisions, we look at risk versus benefit. And in this situation, diabetes is such a comorbidity for worse outcomes with COVID that the best thing to do is really protect yourself, right? So you want to maintain social distancing, you want to mask, you want to vaccinate yourself and lower the rates and the risk of you acquiring COVID. But if you do acquire it, the risk of hospitalization or severity is significantly lower once you're vaccinated. So I would say if you are a diabetic, I would definitely, go ahead and get the vaccine as long as you don't have any other contraindication to getting it, which, the only true contraindication which I've seen so far is when people have anaphylactic reactions to those vaccines, if they do. So that would be one thing you would want to mention. But I would say with the diabetic population, I feel especially concerned, in an environment now with the COVID-19 pandemic for my patients with diabetes, and we've seen a lot of people actually, develop diabetes. Actually, if they didn't have diabetes starting off with COVID, one, because of the virus, but two, also, some of the medical treatment, for example, like steroids, that might be needed if you have diabetes, or even if you don't, you could have a rise in your sugar levels, which becomes very hard to control sometimes. So I would say the best thing is to really gain that protection ahead of time with the vaccine. I think, science has made its advances. We've had evidence-based research showing, the benefits of it. And I think if you can keep yourself at home, safe and out of the hospital with the vaccine, I think that is very, very good for my diabetic patients, especially because, with diabetes also we talk about, the immune system being affected, right? Or slowing in wound healing and things like that. So diabetes predisposes you to many other things, which are also comorbidities like, heart problems, high cholesterol, high blood pressure. So all of these things, like we talked about in our last series, diabetes can really have it's a metabolic disorder. It really has a wide array of effects on
Got it.
almost every body system.
Got it. Thank you. So this next question, totally up to you to answer because it is a personal medical information. So the question is from Eric Dog, who is a great cool bean. Which vaccine has she taken and why this particular one? And totally up to you to say
Sure.
pass.
Not at all. So actually, thank you so much for the question, Eric Dog. So because I'm working in a hospital setting, we were actually one of the first people, to really get the COVID-19 vaccine. I personally got 2 doses of Pfizer. Very timely question on your part. I just got the booster as well today,
Oh,
actually. Yes, I just got the booster. I have my Band-Aid
oh, wow.
to show off.
Very much.
Yeah, so very, very apt timing, Eric Dog, but that was the one that was being offered at our hospital. And I think, the general consensus is that whichever one you can get access to, you should take.
When did you get this one? So it is a fresh bandage. So
Yes,
today? Yes,
just
today?
within the hour of starting the lecture. And as you
Oh,
can see,
wow.
I'm doing perfectly fine. So
I was going to ask you that, hey, did you get sleepy or dizzy? So I think it's going to be another
no.
10 hours. We'll see.
I'm feeling perfectly normal. I went through the whole lecture okay, hopefully. And I don't really have any arm soreness or anything. Obviously, when they first poke you, you have a little bit of discomfort, but nothing after that. I've been okay, touch wood so far.
So, so here is a good question. Are you magnetic at the injection site yet or not?
Oh no, not nothing like
So here
that.
is
See?
another question. Fran Cruz says, when you say diabetes, are you referring only to T1 or T2, or do your response relate to both?
They relate
Or
to
you?
both, they really do relate to both. I've seen a lot of people, my diabetic patients when they do acquire COVID, they always have the risk of coming in something called DKA, diabetic ketoacidosis. And that is, a complication which I would like for my patients to avoid. That is something which can place you in the ICU. So when I am talking about, my diabetic patients getting the vaccine, I recommend that to both. And, oftentimes, even during COVID, we've seen patients presenting in DKA, and then we find out that, they've developed diabetes.
Got it. Next question, couple of more questions. So Svetlana says, in the light of the last statement, so your discussion about the order of the food, about proteins and fat to be eaten before carbs, what could be an ideal plate to eat to? And I wanted to do this as a separate discussion
Sure.
to talk about the food and the ideal plate and the
Yes.
order. So here is a question. So Svetlana, if that is okay with you, we would take up this question a little later. We would also take up the questions around the medications and what medicine does what. For example, I'm seeing this question here from Dr. Amir Hashmi saying which oral hypoglycemic agent safe in congestive heart failure. So we would take those up in the future lectures.
These are great questions. I'm really excited to kind of present these topics.
Absolutely. So let's take one more question and then we will. So again, there are some vaccine related questions which are not related to this topic. So I'm going to take them at a different time.
Sure.
So here, Delilah Davis says, for diabetes mellitus type 2 brought on by steroid, for example, can it be temporary or reversible, or is that a permanent condition?
Yeah, so I actually see a lot of this at a hospital where I work at, where we have a big cancer population, or people who require a lot of steroids. And, once you develop diabetes, it's not something that really can be reversed. It can be managed. You can live a very full life if you're diagnosed with diabetes, but it's something you really have to be important and mindful and taking care of from the beginning. There's a reason they call diabetes a silent killer, is because sometimes when you acquire it, you may not have symptoms. You may not have, the manifestations which everyone talks about, with the numbness and tingling in your hands, the blurry vision. And that's why it's important that you actually take care of it, because it affects the eyes, it affects, your nervous system, it affects your kidneys, it affects so many different things. So you can develop it from, steroids having high sugar levels, and maybe you might have a predisposition to actually developing it, whether that's, through your ethnicity or your lifestyle factors, being overweight, living with obesity. But it can be managed and it can be mitigated. And like I said, I truly believe that lifestyle factors are a huge component of this. So your nutrition and exercise, sleeping well, managing your stress, not smoking, limiting your alcohol intake, all of these things are major in addition to your medications. I know so many people that have managed their diabetes well by just focusing on some of those factors.
Got it. Thank you very much. One more question. I promise this is the last one. Denise TG says, what does she think of things such as L-carnosine for repair of glycation upon tissues and organs?
Do they mean L-carnitine or L-carnosine?
It says L-carnosine over here.
Okay, I'm not
haven't
too
heard
sure.
of this before.
Yeah, I haven't heard of carnosine. I'm wondering if they meant to say carnitine, but I'm not really familiar with L-carnosine. I'm so sorry.
Got it. Thank you very much. So with this, Priya, thank you so much for being here.
Of course.
I think that endocrinology is a fascinating field, and then especially diabetes and the lifestyle and the food and the order of the food and healthy plates and various drugs and the newer advances in managing diabetes and stalling it and slowing it and reducing the complications. These are fascinating topics and important topics. So thank you for leading us through this set of topics.
Of course. And, I think we should definitely touch upon things like, the incretin hormones, incretin mimetics, how that role plays in diabetes management. And we can tie it into the whole series that we did today. So I'm looking forward. Thank you so much for having me. Looking forward to the next sessions, and I'll see the cool bean soon.
Thank you very much. Have a very good day. And nice
Thank
speaking.
you. Thank you.
Bye-bye.